Very good evening to all of you, and thanks for attending this presentation today. I'm going to be talking about a systematic review that we conducted recently and which is currently in the process of being submitted for publication. It's on mHealth for integrated people-centered health services in the Western Pacific region. And this was conducted to inform a Western Pacific Regional WHO initiative looking at harnessing mHealth, or I think specifically harnessing eHealth for enabling integrated service delivery in the Western Pacific. So all of us together at the WHO Collaborating Center, headed by Professor Tang Liao, conducted this review. I'd like to begin, as is customary in Australia, by acknowledging country. And I would like to acknowledge the Cabrogal people of the Darug Nation, the original inhabitants of the Fairfield city area where I now reside. So moving on to the topic of discussion for today, we'll be looking at mHealth for integrated service delivery. As I'm sure many of you already know, mHealth is the use of mobile technologies for health purposes. And integrated service delivery involves several different models or approaches to bringing together different health workflows for delivering integrated care. The framework that we specifically used in this review was the WHO framework on integrated people-centered health services, and that's what you can currently see on the screen. It comprises 5 strategies for delivering integrated care. The first of which is at the top, empowering and engaging people. The second is strengthening governance and accountability. The third is reorienting the model of care. The fourth is coordinating services within and across sectors. And the fifth entails the creation of an enabling environment that in turn enables all of the first 4 strategies. So we came up with the following research questions. And that is, how has mHealth been implemented and evaluated for IPCHS in the Western Pacific region? And what lessons were learned to guide mHealth implementation for IPCHS in the Western Pacific region? So we began by operationalizing these questions. To do that, we restricted our search, because this was a systematic review, to the Western Pacific regional countries as per the WHO regional definition. We looked only at primary studies of readiness, implementation, and evaluation. To operationalize implementation and evaluation, we specifically looked at the RE-AIM framework that looks at reach, efficacy, adoption, implementation, and maintenance. We looked for studies published in the last 10 years at the time of when we conducted this review. That was from the 1st of January 2008 to the 31st of December 2018. And we included, as part of mHealth interventions, the use of mobile technology, as already mentioned, but also wearables, POCTs, which are point of care testing devices, interactive voice response systems, automated or not, GPRS, Bluetooth, and GPS systems as well. We searched 8 databases, namely Medline, PubMed, Embase, the Cochrane Library, CINAHL, Scopus, and Web of Science. We then sourced studies. We then subjected these studies to a qualitative data analysis, which followed principles of thematic coding. We looked at the type of mobile technology used, the service issue that was being addressed, the health issues that were being addressed, the different ways in which the strategies, the 5 strategies of the IPCHS were addressed, and which parts of the RE-AIM framework were addressed by each mobile health technology implementation. All studies were also subjected to critical appraisal, and these are the results. We reviewed 1,219 studies, search results in total, after which we removed duplicates and identified 1,063. 960 were excluded at the title and abstract stage. 103 were then assessed for legibility, after which we excluded 64. And finally, 39 full text studies were included. The first findings were the international variations. As I already mentioned, this was a review conducted to inform the Western Pacific Regional Initiative on harnessing eHealth for integrated service delivery. And so one of the very important policy points is to look at which countries implemented what mHealth technologies and to what degree. So we found 16 studies which originated in Australia, 7 from China, 4 each from Malaysia and New Zealand, 2 each from Vietnam, Cambodia, and Korea, and 1 each from Singapore and Papua New Guinea. Notably, the countries that we did not find studies that were represented from were the Philippines, Mongolia, Brunei Darussalam, Laos, Japan, and the Pacific Islands. Now, I do recognize that it is quite unlikely that, of course, there are no mHealth studies from these countries. It's just that the search specifically looked at integrated service delivery. And so if those keywords were not present, the search would not have picked them up. So that's a methodological limitation. The setting of most of these studies were community-based. In fact, all of them were community-based, mostly within a home-based setting or primary care-based setting. And we only identified 2 hospital-based studies that explicitly mentioned integrated service delivery. So looking more closely at the studies now, we found that they focused on predominantly chronic diseases as far as health issues were concerned. Namely, some examples are asthma, epilepsy, glaucoma, various types of cardiovascular disease, hemophilia, diabetes, HIV, and obesity. There was also a strong emphasis on behavioral conditions, or behavioral management rather, with regard to smoking cessation and alcohol dependency. Service issues that were focused on were in the field of service delivery, diagnostics, scheduling, follow-up, and navigation within the hospital environment, transitioning from pediatric to adult care, prescribing or prescription management, especially within the general practice setting, and medication management. This was both for healthcare workers as well as for patients. Diagnostics includes lab-based diagnostics as well as imaging. Service issues that were also addressed included care of the healthcare workforce, such as the education of community healthcare workers, information sharing between healthcare professionals, and research in the field of primary care. The most common application was non-specific. So we noted that, for example, if an intervention focused on a specific healthcare issue, it would not focus or be non-specific to service issues. And if it focused on a specific service issue, it would be non-specific to a given healthcare issue. So regarding the use of mHealth tools, we found that the most commonly used mHealth tool was text messaging, whether it was automated or not. This was predominantly used to provide reminders, for example, medication reminders, or in the management of behavioral conditions, they served as motivators or facilitators for exercise. They predominantly pushed and pulled information and provided feedback. And in some cases, they were also used to enable decision support, structured telephone support, whether or not it was automated. And there were also several examples of nurse-led telemonitoring or telehealth or telemedicine interventions. There were also several online services that were usually operated through a web portal or a mobile app. These were directed at self-management of chronic conditions. There were some examples of a telephone hotline or an interactive video, for example, where the patient or the person in question could call in to have inquiries answered. These all together acted as part of a larger network of interventions to facilitate a supportive active network that included a provider and sometimes a coach and or a buddy. Now coming to the addressal of these strategies, the 5 strategies that comprise the IPCHS framework. mHealth interventions addressed IPCH strategy 1, which is engaging and empowering people and communities. Some of the mechanisms by which these were addressed included enabling the patient to self-manage their condition. This involved the reallocation of the responsibility of care, and also enabled autonomy in cases where there were care transitions. It enabled the removal of unnecessary gatekeepers, and it particularly involved the engaging of carers, especially informal carers, in caring for example, pediatric patients or patients in aged care. IPCHS strategy 2 was focused on strengthening governance and accountability, and this included accountability in service provision by service providers, as well as adherence to guidelines by community healthcare workers. This example was particularly interesting as it focused on community healthcare workers in Papua New Guinea, where they were implementing malaria guidelines. And so mHealth was used in that situation to ensure that medication dispensing by community healthcare workers for malaria met the set and changed guidelines as well. IPCHS strategy 3 was focused on reorienting the model of care. It included the improvement of accessibility in primary care-based systems. It enabled ambulatory monitoring and facilitated more outpatient care, home-based care. And this was mainly done by innovating and incorporating new technologies. For example, there was one example of a Bluetooth enabled hospital navigation system that was based in South Korea. IPCHS strategy 4 involved coordinating services within and across sectors. In strategy 4.1 and 4.2, this involved again scheduling and navigation. And as shown in 4.3, focused on transitioning patients from pediatric to adult care in the case of chronic illnesses, for example, in asthma. IPCHS strategy 5 focused on creating an enabling environment. Notable examples here involve the use of predictive analytics for ongoing quality improvement initiatives, as well as the provision of CME and e-learning modules for community healthcare workers to ensure that knowledge remained updated and relevant to current practice. Another important part of strategy 5 was the use of different funding models. For example, when enabling the task shifting from GPs to nurses, ensuring that funding models are in place to enable activity-based funding, such that nurses would be able to be reimbursed for their services. Notably, all 5 strategies were addressed by around 28 to 30 studies each out of the 39, except for strategy 2, which was only evidenced by 3 studies. So this could potentially be an area that could be looked at for improvement. We critically appraised all of the studies. We found that there were 20 randomized controlled trials. However, 18 of the 20 scored as high risk on at least one domain in the risk of bias assessment, and 16 scored as unclear on at least one domain, which indicated that the study was inadequately reported to make an assessment. 4 studies were cross-sectional, and all 4 showed issues with internal validity. 4 studies were qualitative, of which we found 3 to be insufficiently rigorous, and 2 lacked a clear statement of findings. 9 were quasi-experimental, under which we identified that 6 had a serious risk of bias, and the other 3 were poorly reported. I think the exact classification was not enough information. So now coming to how the studies evaluated the interventions themselves, looking at the methodology. Of 39 studies, we identified 1 formative evaluation. This was a self-reported formative evaluation. 3 described themselves as being process evaluations. And out of 39, 10 were theory-based evaluations. Just to clarify, a theory-based evaluation is one where the evaluation clearly describes the program logic, the program theory behind the intervention, and evaluates various outcomes or processes along that program logic. So only 10 explicitly made the program logic clear when conducting their evaluation. Now, regarding evaluation measures, 28 evaluated cognitive and behavioral outcomes, 10 evaluated technical outcomes, that's issues such as usability of a particular app or software or system, feasibility, user satisfaction, and so on. 7 measured health outcomes, so these would be actual improvements in health status, either as a health-related quality of life or otherwise, and 1 measured service uptake and adherence. So this is resource utilization outcomes. So in evaluating the implementation of these interventions, we, as I mentioned previously, looked at used the RE-AIM framework, which comprises of assessing reach, efficacy, adoption, implementation, and maintenance. So we found that reach was usually assessed by using indicators of uptake or coverage, and these were predominantly quantitative. Efficacy involved indicators such as, or measures such as adherence or clinical outcomes, and these were also quantitatively measured. Adoption was predominantly measured using qualitative methods, and there was a lot of emphasis on the barriers to adoption, such as integration with existing systems, lack of funding or lack of motivation, and the underlying reasons behind those barriers to adoption. Implementation, and by this we mean the scale up, was rarely described, and maintenance too, or the factors behind maintenance, were rarely described. Although wherever they were described, they were predominantly qualitative. So just to bring this back together, with regard to the key takeaways from this research, we noted considerable international variation, and quite importantly, there was underrepresentation of some countries. So this is something that in our report to the WPR team, this would require more attention in improving eHealth for integrated service delivery in the Western Pacific region. mHealth was commonly used to address chronic and non-communicable diseases. It was mainly used to address service issues rather than health issues. Although in the current climate of COVID-19, this is something that we anticipate we will see changing, especially when it comes to managing the long-term impacts of COVID, especially in the primary care or home-based setting. We found that mHealth definitely can be used to address the IPCHS strategies, although there is scope for progress, specifically with attention to Strategy 2, where there is a need for improving participatory governance and mutual accountability. There is also a need when it comes to methodology for better reporting of implementation studies. And with regard to this, we draw attention to the Standards for Reporting Implementation Studies Initiative, or STARI. And I think the guidelines for this has been published a couple of years ago. So anyone working on reporting implementation studies, this is something that can definitely have more attention paid to it. Also, I guess implementation of this in particular comes down to the engagement of stakeholders and the responsibility on authors and journals to ensure that studies are adequately reported. There's also a need, particularly when it comes to reporting programs, to have attention paid to theory-based evaluation in the case of complex interventions. So being more explicit with the program logic of how the program is expected to work. This is definitely quite difficult in terms of complex interventions because the causal links may not always be clear, but it is always possible to, using approaches like the critical realist approach to make an educated guess about how the program is intended to work, and then critique that through the findings of the study. We also anticipate that there's a need for building more capacity in methodology of implementation science with regard to the use of various methods. For example, both qualitative methods as well as quantitative methods. Both of them have a role to play in implementation science. It's not just about doing randomized control trials, but especially in process evaluations and trying to understand how programs work and how program logic can be made more explicit. Qualitative evaluations, process evaluations, and formative evaluations can play a very significant part. And so this is something that we would like to see more of in the future. Finally, when it comes to the evaluation of adoption, implementation, and maintenance, we recognize that there's a need for greater institutionalization in order to prevent the epidemic of mHealth pilotitis, that I think is something we're all quite familiar with. Because emphasis is placed on the first two aspects of the RE-AIM framework, that's the reach and efficacy, in order to move from there to more widespread organizational adoption, implementation, and maintenance, we need to think more clearly about organizing system structures and the environment itself to enable a greater institutionalization of mHealth interventions within those systems and structures. And that ultimately mHealth is something that's supposed to be used to improve service delivery and not just to publish and to be done with. I think that wraps up my presentation for today. Looking forward to questions from you all.
All right, sir, we have our first question, and it reads, could you give a concrete example of mHealth, especially in settings with limited resources?
Sure. One that comes to mind immediately was the use of mHealth in ensuring adherence to worker guidelines. It was studied by Kurumop et al. I'm happy to share the reference. This was based in Papua New Guinea, where access to textbooks and malaria guidelines were limited in rural and remote areas. And so mHealth was used to ensure that not only did community healthcare workers have access to those guidelines, but that they were able to learn the guidelines and apply the guidelines effectively. And this was entirely done over SMS. Another one that comes to mind was a study by Ma et al. Based in rural China. I think it was based in the Tibet Autonomous Region of China, where nurses implemented telenursing project for the management of hemophilia. And hemophiliacs had access to, the hemophiliacs that were enrolled in the program had access to a telephone hotline where they could call in and be guided through the management of acute emergencies in hemophilia. So, for example, bleeding events. And the nurse would provide them with information over the phone as to how they could manage those acute bleeding events and prevent complications as a result of hemophilia. So that's another example of management of mHealth being useful for integrated care in rural and remote areas where resources were scarce.
Thank you,
Hope
sir.
that answers the question. Yeah.
Yes. Our next question is, how do you think these findings could translate to other geographical regions in the world?
I guess that would really depend on the needs of the specific region in question. The Western Pacific region, for example, is quite diverse in terms of the socio-cultural and geographical and even geopolitical makeup. And so the translation of these findings into specific regions would, I guess, have to be considered on a case-by-case basis. Integrated care is something that happens not only in rural and remote areas, but also in cities. And so one important part of integrated care, or particularly the IPCHS framework, I think is strategy number 3.1, which looks at the importance of ensuring that care delivery is specific and suitable to personal preferences and social preferences. And so it's also important to consider the cultural expectations when it comes to those things. For example, there was a study comes to mind, a study by Bangash et al., which looked at, I think it was a study by a urology resident who was looking at patients' preferences with regard to the sharing of information or images pertaining to urological conditions. And of course, pictures of reproductive organs were something that was quite sensitive. And so the study looked specifically at that and found overwhelming evidence, for example, that in that setting, that patients were not averse to the sharing of those images as long as they were not identifiable. So this, I guess, comes back to issues of data privacy and ensuring that information is secure across networks. So yeah, it definitely will vary on a case-by-case basis and also by specialty, as this example shows.
Thank you, sir. Our next question is, to what extent are smartphones needed for mHealth? Is there the risk that people will be excluded because they don't have smartphones?
Definitely. There's definitely that risk. In our analysis, we did not specifically look for the determinants of the digital divide, as it's increasingly being called. For example, a colleague of mine, Samira, looked at the role of age and in causing that digital divide, and so that's something that is definitely a reality, but it's not something that we specifically looked at. With regard to smartphones specifically, to what extent are they required? Well, by far the most popular mHealth modality that was used was text messaging. And so since text messaging or short messaging services, SMS, do not require smartphones, I guess a strong argument could be made that smartphones are definitely not essential. That being said, almost every other mHealth modality, apart from voice calling, required the use of a smartphone. For example, using a mobile web portal or using a mobile app. Video conferencing technologies, point of care testing, some of the diagnostics required the use of a camera. There was definitely the use of GPS, for example, and Bluetooth in the in-hospital navigation systems. So I think increasingly, as the demand for more complex systems is increasing, people are finding that smartphones are more capable than non-smartphones.
Thank you, sir. We have our next question. So did any of the studies discuss governance structures or their immediate environment, political, technological, or otherwise? And what was the impact on their interventions? Or was governance under-researched across the studies selected for the systematic review?
That's right. The second part of that statement pretty much sums it up. I think we found that governance was definitely an issue. It was mentioned a couple of times with regard to the barriers to adoption and barriers to implementation. But overall, with regard to participatory governance and mutual accountability, that's IPCHS Strategy 2, there was little to no emphasis on the role of governance. I guess this might come down to issues with the reporting of studies themselves. Studies tended to focus on the reach of a particular mHealth intervention, the reach and the efficacy of that particular intervention. I guess this stems from looking at, I guess, the idea of efficacy, or a more Cochrane sort of approach to the success of any given intervention. But thinking more, I think what we need to move towards is more looking at mHealth interventions as being one cog in a larger wheel, or one spoke in a larger system, where they play a part as part of a more cohesive system, and that requires greater attention to governance, and particularly participatory governance, where the patients and the carers and the communities themselves are more engaged in enabling the mHealth intervention to do what it's supposed to do. Because at the end of the day, the mHealth intervention it's a digital system, but those systems are designed to implement humane outcomes. They're meant to enable people-centered care or person-centered care, and I think that needs to become the center of this. And governance, of course, is a huge part of that.
I have another question. So was there any focus on the role of payers, such as health insurances, in upscaling mHealth? They could play a role in adoption, implementation, and maintenance, right?
There was not much emphasis on the role of payers per se, but there was a study, for example, that looked at how nurses could be more helpful at the primary care level for patient management and enabling of self-management, ambulatory care, and outpatient management in GPs' practices. And they noted that one of the barriers to these more shared primary care systems was the lack of funding models. So ensuring that the funding that comes in, it was an Australian study, to be fair. So understandably, where we have a single payer system and it's predominantly done by bulk billing at the primary care level, the role of the payer isn't as much in question, but how that funding gets distributed, I guess, according to activity-based funding or results-based funding, that was definitely a question. It wasn't, of course, it was just listed as a barrier, but not specifically addressed in that particular study.
Right. I guess if that is the last question, we can wrap up this call. So thank you, Sir Myron, for sharing your time and expertise to the AeHIN community.
Happy to. Thank you.
Thank you, everyone. Bye.
Good night. Thank you all.